topic. Our new topic this week is bundle branch blocks. And I know this slowly just keeps adding and adding, and I want you to remember to go back, look at previous lectures, go back and look at some of the slides. So bundle branch blocks are a really interesting thing. So last week was AV blocks, right? We're looking at the PR interval when you look at an AV block. Bundle branch block is a little bit different. Obviously, it's got a different name. So what we're going to take a look at with bundle branch block is what causes it, the pathophysiology of the right versus the left, what it looks like on the EKG criteria, understanding the causes of them, the treatments for left versus right bundle branch blocks, clinical implications, and understanding the difference at the very end, just very, very little hemiblocks versus bivesicular blocks on the EKG. When you think about an electrical conductions from the right and the left bundle branch results in a uniformed contraction of both ventricles. So think about this. We start with the SA node, it goes down to the AV node, and then from the AV node it divides into left and right, his bundles, left and right side. If there is a delay going down the left or the right, his bundle branch blocks, those in the left or right ventricle, if there's a delay, we call it a block, right? So that depolarization that's coming from the SA node to the AV node, and then it divides to left and right, his bundle branches, as it goes down that conduction track, that is what can develop what we know as a bundle branch block, right? A delay. So let's first take a look at the left. So bundle branch blocks, without me even telling you, I'm going to let you know that we're looking at the QRS. So let me just go back. Last week's AV block, an AV block, first degree, second degree, third degree AV blocks, right? First degree AV blocks, second degree, either Wenckebach or Mobitz type 2, and a third degree. All of those, you're looking at the PR interval. Now I've got the same terminology block, but now I'm talking about a bundle branch block. So now we're a little further down in the heart into the ventricles, left or right, his bundle branch. So when you take a look at a bundle branch block, guys, your eyeballs, your eyes, your head, your mind is focused on the QRS. Let's talk about what about it. So with the right bundle branch block, the conduction abnormality is going to be obviously in the right bundle branch block, right? That's what it's called. And it's delaying depolarization down that right ventricle. Usually non-pathological, usually not a big issue. People can be healthy, asymptomatic individuals. Somehow there's just a little bit of delay moving down that right branch. Symptoms might include low heart rate, pre-syncope, syncope, so a little lightheaded dizziness. What does it look like to you? Okay, so think about this. You've got a little delay going down the right bundle branch block. You can have a wide QRS complex. Remember, the QRS is what we're looking at. What do I mean by wide? Well, remember, a good-looking QRS from, I don't know what chapter that was, the beginning, right? What is a normal sinus rhythm? Remember, a good-looking QRS is less than 0.10. So the definition of a wide bundle branch block, a QRS, is going to be bigger, greater than 0.12 seconds, and we're looking at the right side, so we're looking at V1. Remember, that's the electrode over on the right side of the sternum. We also can see what we call an RS prime pattern in V1. We also can see inverted T waves. A strain pattern in inverted T waves may be present in the right chest leads, and you can also see wide S waves in lead 1, and lead 1 is different than V1, right? Roman numeral 1 and V6. So let's take a look at what I'm talking about. Okay, so here's a QRS. Look at your eyeballs here in V1, right? You notice some kind of little hiccup over here. So here in V1, we see that it's wide. If we count out the boxes of that QRS, it's wider than 0.10. This S prime is an important thing to look at. Inverted, again, you could see inverted T waves. You could see a very deep S wave. But the big hiccup is always going to be kind of our strange looking thing here in V1, right? That's what we call that prime. We don't really know what the causes are. Idiopathic changes, aging, heart rate exceeding the threshold could be age-related, atrial septal defect at birth, a congenital thing, myocardial infarction, pulmonary disease, myocarditis, hypertension. I'm listing you all of these potential causes, bottom line is a right bundle branch block is benign, asymptomatic, no big deal. So what are you wanting to think? An R prime pattern in V1, the R prime smaller or equal to the amplitude. When I talk about prime, you're thinking, what in the heck am I talking about? When you think about an R prime, I want you to think about how this we don't usually see this notch, right? The R prime is one, it should just be one R wave, right? So QRS. This R wave, we've got like a second R wave. So when I'm talking about these R primes, it's the pattern of the R prime is smaller or equal to the amplitude of the R wave, which is what you saw right here, right? This R prime and this R wave. Sometimes you hear books call these rabbit ears, right? Like a set of rabbit ears. Anyways, QRS may measure, again, wider than 0.10, and this is, so what makes you on the test pick a right bundle branch block? Well, you're looking at V1, you see R prime, rabbit ears, in V1. You also count the boxes of the QRS, and it's greater than 0.10 seconds. You guys got that? So right, how do I know, how do I pick this on the test as being a right bundle branch block? I look at my V1, I have an R prime, rabbit ears, right? A little notched R wave. We see it predominantly on the right side, right? You see it right there on V1, that electrode's on the right side. We also count the duration of the QRS, and that is what's going to give us that right bundle branch answer. Let's flip to the other side, which is a left bundle branch block. Conduction abnormality through the left bundle branch block. Again, delay in depolarization of the left side. This is different. Clinical sign of underlying heart disease. We do not have that on the right bundle branch block. The left bundle branch block does bring with it a clinical diagnosis. Muscle damage has happened to the ventricles. Similar, it's going to again be similar. We've got a wide QRS complex, so greater than 0.10 seconds, typically notched wide QRS on the right chest leads as well. ST segment changes in the opposite direction of the QRS complex in the chest leads, and this is what we talk about, strain pattern or inverted T waves. So the left bundle branch block, we usually don't see the septal Q wave in the left chest leads. We do usually see tall notch R prime pattern in the left chest lead. We also commonly see left axis deviation. Remember left axis deviation, right? So remember how to do axis deviation, what's going on with lead 1, what's going on with AVF, all of those things. Okay, so let's take a look at what this looks like on the EKG. Very evident, I hope, is you see these big wide QRSs. Look at the duration of the QRS, right? Every QRS is bigger than 0.10 seconds. We see very, absence of the septal Q wave, very big looking QRS complex is the other big thing that we see. I always feel like the left bundle branch block, it's just wide and strange looking, right? This big wide QRS, it's evident everywhere, right? That's our left bundle branch block. So what else do I want to remind you of? We can take a look that we're not in normal axis deviation, right? So lead 1 is positive, lead AVF is negative. So that's not normal quadrant. So remember, how do you tell axis? You look at what's going on in lead 1, meaning positive, double thumbs up, right? Positive, this lead, but in our AVF it's negative. So it would be a not normal axis deviation. Left bundle branch block has usually caused some significant heart disease. So aortic stenosis, cardiomyopathy, myocardial infarction, not a heart attack, basic extensive coronary artery disease, hypertension, just lots and lots of heart. We see a lot of left bundle branch blocks with people in cardiac rehab, obviously, because they have heart disease. They have known heart disease. So exercising somebody with a left bundle branch block in cardiac rehab happens a lot. They sometimes need a pacemaker. They are usually going to be on medicine, intraventricular conduction. It's usually going to be seen left anterior descending artery is usually the artery that's injured. So our left bundle branch block, when performing a treadmill stress test on an individual, it can convert from normal sinus rhythm into sinus rhythm with left bundle branch block during exercise. What am I saying, guys? At rest, you might see what you would classify as normal sinus rhythm, but we call it exercise-induced left bundle branch block. That while exercising, their body needs more blood flow, it's getting a little ischemic, and then they go into a left bundle branch block during exercise, and then after rest, and during recovery, they go back to normal sinus rhythm. This is called a rate-related left bundle branch block. It's uninterpretable by the EKG criteria, because what happens is that you really can't see that when someone goes into left bundle branch block, the ST segment, it becomes very skewed, and we cannot therefore use the EKG as interpreting the exercise stress test as a diagnostic test, and they would have to go for an echo. Hemiblock is something a little different. Vesicular hemiblock, left bundle branch block, separates into anterior and post. So let me tell you, this is going down at a smaller level. So first we have, do you have a bundle branch block? Yes, no. Bundle branch block means you have a QRS wider than 0.10. Next layer of the test, is it right or is it left side? A right side bundle branch, V1. A left bundle branch block, you're going to see changes in the morphology of the EKG on all those 12 leads. When we look at the hemiblock, we're looking at the hemiblock being, is it anterior or is it posterior hemiblock, which is really kind of confusing. So left anterior and posterior fascicles of the left bundle branch block. So again, here's the left bundle branch itself, right? It comes down. If you want to be really go a little deeper into this, we can take a look at, is it going to be the anterior fascicle or is it going to be down here more of the posterior? So the left anterior hemiblock results in a left forward shift of electrical axis towards the path, what we call left axis deviation, versus the posterior hemiblock results in the right, usually right axis deviation. This is a lot of information. So this is now combining your axis deviation with how that conduction is moving through the heart, right? That's what axis deviation is telling us. And now taking a look at the left bundle branch block, we can tell if it's going to left axis deviation versus right axis deviation based on where that block is happening. I am not going to get this specific with you. This is information overload, so don't worry about the hemiblocks. I have it here in the slides to share with you about hemiblocks. I'm not going to ask you about hemiblocks. Bivesicular blocks, right bundle branch block. Again, this is a lot more finite. I think I'm just going to throw it out there and say these exist. What do I want you to know from this lecture is a bundle branch block is a wide QRS complex greater than 0.10, right? That delay has happened down the conduction block, so we have a wider duration of the QRS. Is it right or is it left? Look at those V's, V1 through V6. What's going on with the shape of the Q wave?